But we're going to switch. I'm going to go first, and he's going to join me. Let's see, is there a pointer? Yes, this will work. Great. So I'm going to talk a little bit about malignant melanoma. There's a lot of new interesting things that are in our field about melanoma that's dermatologists, both in diagnosis as well as treatment and therapy, as well as prognosis, interestingly enough. These are some of the issues that we have to deal with in histologic diagnosis. I won't read all of these to you, but basically what I want to start off with are things that we refer to as sheep and wolves clothing. These are benign lesions that actually tend to be overcalled a lot of times. And so basically you'll see this, many of you. Some pathologists kind of put things down to kind of cover themselves, if you will. And again, unnecessary hedging is not a good thing in dermatology or dermatopathology. I always tell our fellows we want the three bears, not too hot, not too cold, just right. And that's what we try to do in our field as much as we can. So I'm going to just show you a few of these that sometimes tend to get overcalled. If you look at certain parts of the body, nevi in those parts of the body have funny features sometimes that can be easily confused with melanoma under the microscope. The flexural areas of the body, the groin, the breast is a very common location where you get some slight pagetoid spread and some epithelioid melanocytes. Often gets overcalled as melanoma. I'll just show you a few examples of some of these. This is a genital nevus, totally benign lesion, and these often will get these large nests of cells with some of the melanocytes being slightly larger. Occasionally you'll see a cell or two above the junction, but no mitotic figures. The lesions are architecturally benign, symmetrical, well circumscribed, not really, it shouldn't really cause confusion with melanoma. Volar skin nevi, again, these tend to get pagetoid spread. These have been referred in the literature as so-called maniac nevi. Again, you may get a few cells above the junction, but usually relatively few in the cornified layer, and usually no striking atypicality or mitotic figures of these lesions. The ear, these lesions commonly give a spitzoid morphology, and this is repeatable. We see it all the time. It's not to be overcalled as melanoma. We had a case a few years ago of an ear lesion of a 21-year-old executive in the Dallas area, got overcalled as a desmoplastic melanoma, and it was scheduled to have his ear removed, and it was just basically one of these spitzoid lesions on the ear. And you'll see this very, very frequently. If you get back a lesion that comes back as melanoma on the ear of one of your patients and you really don't think it's melanoma, go back and tell them to review it and maybe get a second opinion. Sometimes congenital nevi, you get single melanocytes overlying the dermal component of these. It gets overcalled as melanoma in situ, not uncommonly. And then we see proliferative nodules that develop in congenital nevi that can simulate melanoma. This is an example of an obvious, relatively small congenital nevus, the obvious nests of melanocytes here in the dermis, and then the single melanocytes within the epidermis, which is fairly common. Again, you usually don't get much pagetoid spread, maybe an occasional cell above the junction, but no mitotic figures, and this is usually confined to the areas above the dermal component of the nevus. Now, if you biopsy a congenital nevus shortly after birth, usually within the first few months of life, but sometimes up to a year, you can get some striking pagetoid spread of melanocytes throughout the epidermis. These are usually mostly arranged in nests, and what we think is going on here is that in the embryo, these nests are present throughout the epidermis, and they go down into the dermis as time goes on. This is just you're capturing that fetal embryologic finding after the child has been born. Usually you'll see no atypia, no mitotic figures, maturation of the cells in the dermis beneath that. And so you're looking for nests predominating over single cells with few, if any, mitotic figures in the maturation. So again, one of the worst things you can do is overcall a melanoma in a very young child. So we always put the brakes on and look for these simulators. And this is another one. One of these giant congenital nevi, they often will get these large aggregations of melanocytes. They can have some mitotic figures. Generally, they undergo maturation, and there's some minimal pagetoid spread. So here's one of these lesions that developed in this congenital nevus in this kid, and this is not melanoma. These are just proliferative nodules that developed within the congenital nevus. So the cells are kind of large, but they're not really strikingly atypical. If their mitotic figures are usually relatively few in number, so this is another simulator of melanoma that you just need to know about. Now, we're also seeing a lot of clinicians using immunoperoxidase staining to determine the surgical margins of melanoma on sun-damaged skin. Now, the problem with this is that there's background melanocytic proliferation. This is kind of a field cancerization phenomenon, And if you start using these stains, you're going to stain just about every melanocyte that's in there. These are very, very sensitive stains. We see a lot of solar lentigines that get overcalled as melanoma. So again, here's the melanoma, but you know if you went out and did an immunoperoxidase stain of the skin over here, it's going to be positive because there's obviously melanocytic proliferation due to this extensive sun damage that this patient has had. Same example here. So this is an example of punch biopsy of a melanoma in situ. You can see the melanocytes at the dermal junction here. And this is the immunoperoxidase stain demonstrating this confluent melanocytic proliferation at the junction. This is a solar lentigo. Looks no melanocytic proliferation here. These are all pigmented keratinocytes with these bulbous epidermal rhescia here. And this is the immunoperoxidase stain here. It's also very strongly positive. And I've seen Mohs surgeons overcall this as melanoma, and they just keep cutting and cutting and cutting. And if you do that, you're never going to get an empty, free site. And they'll get defects that are several centimeters in size, and they really don't need to be. This was a real-world case of an older man that came into the pigmented lesion on his face. The Mohs surgeon had done this, and they weren't getting any free margins, so they sent it over for us to take a look at it. This is just freeze artifact with some melanocytes at the junction here. Obvious solar lentigo by frozen section here. And this was their immunoperoxidase stain, and they were interpreting this as positive, and they just kept cutting, and they didn't know when to stop. So beware of using these stains in Mohs surgery. You can overdo it and end up getting extremely large margins when you really don't need them. Well, what's a way out of this sort of pitfall, if you will? Well, this is one of the things that we like to do. Take a Woods lamp. That can kind of give you an extension of the true pigment of the melanocytic lesion. Take a 5 millimeter margin around that. You can also consider biopsying another area just to kind of see what the background melanocytic proliferation is there. If you still have obvious melanocytes at the surgical margin, you can consider using postoperative imiquimod to treat this. So here's an example. Here you see the melanoma in situ in this guy's nose. Would you say a Woods lamp on it, this becomes much more obvious, and then you take your margin around that area, and then you end up getting a free surgical margin there. Now, there's been some debate in the literature whether 5 millimeter margin for melanoma in situ is really enough. And this kind of famous article now published by Zitelli's group a few years ago, they said that they looked at a number of melanoma in situ and they said that they needed a 9 millimeter margin. Well, one of our residents at UT Southwestern decided to study this a couple of years ago, and basically they were thinking that maybe some of the explanations were some of these. Maybe they were overinterpreting solar lentigo or this melanocytic proliferation as residual melanoma in situ. Maybe they were using this IPOC stain and getting two large areas that were recommended to be removed. And so they actually did this technique, and what they actually found was that melanoma in situ was actually present in a relatively small number of cases, only one case outside the 5 millimeter margin using that technique. And for those that were invasive melanoma, nothing was outside the margin. So they got 95% clearance. This is kind of what we see in our lab. We get 5 millimeter margin melanoma in situ, so this is more kind of what we see in the real world, not at tertiary referral centers. So this is maybe a little different than these Mohs units, so this is really a very reasonable approach, and you don't need to take a centimeter or larger around these lesions. Now let's kind of shift gears a little bit. Those are the situations where you can overcall melanoma. Let's take a look where you can undercall melanoma. This is a more dangerous situation where lesions can lead to misdiagnosis and medical legal problems. Blue nevus-like melanoma, these are often, can be easily misdiagnosed as cellular or combined blue nevi. They often look kind of symmetrical. They may be vertically oriented. You may have relatively few atypical cells. So you have to have a high index of suspicion, consider genetic testing. Here's an example of one of those. They did a punch, which unfortunately punch biopsies tend to make things look benign when they may really be malignant. We'll talk about that a little bit later as well. You can see there's really not much going on in the epidermis here, but if you start looking down here, these cells are somewhat pleomorphic. There's a mitotic figure here, and here's an atypical mitotic figure here. We recommended removal of this lesion. This was before we had FISH, before we had other genetic tests, which we would submit this to now, by the way. We'll talk about that a little bit later. She actually ended up having sentinel lymph node biopsy, which had lots of atypical melanocytes in two lymph nodes. So beware of that blue nevus-like melanoma that looks benign. Poorly differentiated spindle cell neoplasms, these are the classic differential diagnoses, or a few others, but basically all of these look the same with H&E. You really need special stains to determine them. This one was HB45 positive, turned out to be melanoma. Another one that's poorly differentiated turned out to be atypical fibroxanthoma with a CD68 stain. And this last one was positive with cytokeratin, a squamous cell. So when you're dealing with a poorly differentiated spindle cell lesion, you know it's going to be cancer, but the prognosis of a squamous cell or AFX in a melanoma is strikingly different. So you want to make sure that you get an accurate diagnosis there where possible. Here's an example of a lesion we had a few years ago. It was sent in as rule-out squamous cell carcinoma. You can see it's got this verrucous epithelial hyperplasia here. It's also got this zone centrally where there's really not as much differentiation, but it's contiguous with the obvious epithelial differentiation here. So it would be fairly easy just to call something like this a squamous cell carcinoma that's poorly differentiated. This is what the actual lesion looked like clinically. Maybe some hemorrhage into the lesion over here on severely sun-damaged skin. Well, this was the immunoperoxidase stain. This is cytokeratin, highlighting all the keratin-positive areas here, the squamous elements, but did not highlight that more poorly differentiated area centrally. This is the S100 protein stain, which is almost like a photographic inverse negative of that, showing staining here without staining the epithelial component. So this was an example of a verrucous malignant melanoma. It's a very relatively rare variant, one that we do see on occasion. So again, you want to make sure that you use these stains appropriately. And if you get something that's poorly differentiated, don't just assume it's something. You need to stain it up and prove what it is, which we can do today. Now, this lesion here is almost really more like a soft tissue neoplasm that you see. It's really a type of melanoma, desmoplastic melanoma. They usually occur in older individuals, may be associated with melanoma, linear-malignant or melanoma in situ, but may not be. And these are usually positive with S100 protein, but sometimes the S100 protein staining is weak, spotty, or negative. So don't just assume that that's always going to bail you out here. SOX10 is positive, but these stains, HMB45 and MART, are negative in about 85%. These can look like scars. They can look like soft tissue neoplasms, like neurofibromas. Here's an example. It looks very much like a neurofibroma. It's got this loose, delicate myxoid stroma with these spindle-shaped cells that have these S-shaped nuclei. If you just saw a field like this, there's no way you would ever call this a melanoma. Again, looks very much like a neurofibroma. In one or two tiny areas, there was some overlying melanoma in situ. And that's the only way the diagnosis was made. Here's an example. This, believe it or not, is a desmoplastic malignant melanoma. If you saw somebody like this coming into your practice tomorrow, you'd probably just be concerned more about the actinic keratoses up here, and you really would think, well, maybe he had an area that was frozen like over here, perhaps. Looks almost identical, but that was a desmoplastic malignant melanoma. So that's something that can give you a nightmare because we all see patients like this in our practices all the time. You have to be wary of these special stains. This was an example of a lesion here. Again, very nondescript. This could be many things. I don't think that melanoma would be number one on your list if you saw something like this clinically. They did a punch biopsy here, and it shows this diffuse proliferation of these spindle-shaped cells. Looks very much like a neural lesion once again, not strikingly atypical here, maybe a little pleomorphism, but not any mitotic figures or striking atypicality. They did an S100 protein on this, which was negative, and a CD34 negative, and also did a stain for actin, and they said, well, these cells are staining, so let's just call it a leiomyosarcoma. At least they called it malignant, which is good. So they went back and did an excision on it. They didn't get it all out, went all the way down to the base, went to the sides here, and some little lymphoplasmacytic aggregates were noted in these sections, and then the same sort of changes that were seen before. They repeated the stains once again, and guess what? The second time the S100 was positive. So the literature says these should be positive up to 100% of the time. In this case, the punch biopsy was negative for S100 protein. Still turned out to be another example of a desmoplastic melanoma. So just be wary of that sometimes the stains really don't always bail you out. You have to put them together. We do see a lot of cases where the biopsy staining is different than the excision staining. So that's something else to remember. There are other pagetoid neoplasms. You can see pagetoid patterns in a lot of different things. Here's an example of one. You see the pagetoid intraepidermal neoplasia here. And in the dermis, you see this little duct. This actually happened to be Paget's disease of the breast, which can simulate melanoma. But just remember that the pagetoid neoplasms are not all melanoma, but they certainly is one of the patterns that you can see. This is a CEA stain that was positive here. Now, I was asking in the other room, are we using molecular techniques to assist in diagnosis of melanoma? We certainly are. There are a lot of different lesions where we use them. Spitz's nevi is a very helpful thing. We're dealing with these atypical spitzoid melanocytic lesions. This is why we will use these techniques. This is an older case, but it demonstrates the difficulties we sometimes have in dealing with a spitzoid lesion. It's a shaved biopsy. Looks very much like a Spitz's nevus, was called a Spitz's nevus. Nests of cells that are spindle and epithelioid. This was taken from a young woman, and here you see some pagetoid spread that we commonly see in Spitz's nevus. This is another lesion also taken from another relatively young woman. Again, this looks even more like a Spitz's nevus than the other one to me, and this was actually signed out as a melanoma. The second one was excised. The first one was not excised. Well, the first lesion, about 18 months later, looked like this. So it was actually a melanoma that had been sampled looking like a Spitz's nevus. So this is why we have these stains. This is why we have these techniques now that we're using to try to distinguish, because nobody wants to undercall that and end up with a medical legal case, as that one turned out to be. Fluorescence in situ hybridization, this is a technique that we're using a lot now. We're looking at these specific genetic regions in the genome. One of the most important ones is 9p21 area. These, basically what you do is you look at the area, you find the most atypical areas, and then you count cells. This basically, you're hybridizing these areas of DNA to the genome, and you're looking for specific dots that get produced and produce these kind of images here under fluorescence microscopy. So one of the things that we're looking for is specifically gains or losses of areas. Deletions is homozygous 9p21 deletion is very important. It's associated with highly aggressive behavior in these spitzoid lesions. These tumor suppressors live in this area. So again, if we get a 9p21 deletion, we get concerned about these atypical spitzoid lesions. Here's an example of paper that shows this 9p21. There should be dots here. There's nothing here at all. Another technique you can use is take a look at the entire genome, so-called comparative genomic hybridization, where you take the tumor DNA and you take normal DNA, you hybridize it. Normally green and red leaves no color. If you see green, it's overexpression, red's underexpression, and you're looking for these kind of images here. You can actually couple that with laser capture microdissection, where you're taking out small pieces of an actual tumor and doing the same technique. And now we have these what are called array-based comparative genomic hybridization. We're actually using these microarrays. These can detect more specific areas. They have these very sensitive, fast, and they're high throughput. Again, this is becoming more standard of care than these other techniques. And you'll also read about microRNA, where you're looking for specific non-coding areas that are amplified or decreased in some of these, silenced in some of these tumors. So these are things that we're not using as much today. They're using other types of pathology, but they're going to be more available to us in the future. You can also now profile melanomas. Again, these are very specific genetic mutations that you're looking for, and specifically we're looking for mutations especially in the BRAF pathway. These are mutated 60 to 70% of the time. There are others that get mutated, NRAS, c-KIT, and these others. Again, the BRAF gene, there are 3 of these, A, B, and C. The B is the one of most importance, and it's part of this serine threonine kinase pathway. It's a mutation that occurs specifically, a glutamic acid and valine at this position 600, so that's why it says V600E, and this is by far the most common. This results in more active kinase activity when it's mutated, which results in the cells producing more, and that's why you end up being these are associated with melanoma. This is one of these Sanger sequences that you see. If you get 2 peaks, it means that there's a mutation. And this is that pathway that we talked about here, and there are drugs now that are developed to target each one of these molecules. We now have combinations that will hit both RAF as well as MEK, and even now we have ERK inhibitors. So this is very exciting stuff now that we can actually treat melanomas that we really weren't able to do just a few years ago. You can also use these molecular diagnoses for other Spitz's nevi. You usually don't get BRAF mutations or NRAS mutations in Spitz's nevi, but you can get HRAS mutations. So we see that tends to favor a Spitz's nevus. There have also been in the literature in the last few years some of these clinical pathologic genetic variants of Spitz's nevi, which are interesting. This BAP1 3p21 deleted epithelioid nevus, these atypical spitzoid lesions with 11p gains, and then these ALK fusions. Again, this is a mutation that occurs at this site here, and these cells get these very, very large cells looking kind of like this. We see this occasionally in our laboratory, and they have this sort of pink dome-shaped morphology. They usually don't get epithelial hyperplasia or caminobodies in them. So again, these very, very large BAP1 mutated nevi. This sclerosing Spitz's nevus with 11p gains with or without this HRAS mutation. Again, these tend to be desmoplastic. They're large, they're kind of bulky with these fusiform kind of morphologies. And then lastly, we can see these Spitz's neva with these ALK fusions. This is where we have genes that from different chromosomes fuse. These result in oncogenic activation or proto-oncogenes that become activated, and some of these are seen in Spitz's nevi. They're still benign lesions, but it's interesting that you see these two different ALK mutations. They tend to be plexiform with these intersecting fascicles of cells and an overlying verrucous epithelial hyperplasia. So you see this histology, you see the genetics. And it goes all the way back to the molecular biology, which is really kind of interesting. We didn't really have that very long ago. We now have genetic testing to help us make diagnoses. These are more objective. These are things done in a PCR lab. You don't have to look at anything under the microscope here. You just take tissue, you put it in a PCR, you're looking for 23 different genes to get analyzed, so it's a little different than FISH, which is somewhat subjective. You end up getting a melanoma diagnostic score. These are some examples, and this is being done by the company Myriad, MyPath. I am a consultant for that group as a disclosure, and we use this in our laboratory quite frequently. I just had used the other day on an atypical spitzoid lesion that came back with a result of 3, and we changed it from atypical, not certain, to melanoma. So it was very helpful in that situation. But you do have to be aware of over-relying on these techniques. This was an 11-year-old boy that came in with what I thought was a pretty classic Spitz's nevus. To me, this looked pretty easy. Wouldn't really even have hedged this at all. And they actually showed it at their conference, were concerned about it, did FISH on it, found some abnormalities, and they just decided to call it straightforward melanoma, which was basically, in my opinion, incorrect. I'm not a big fan of these syntopic reports because they make it look accurate when really everything was wrong here. So it looks great, but it just happens to be totally incorrect. So the right diagnosis here was a Spitz's nevus rather than a melanoma. So again, I think you just have to be wary of over-relying on these techniques, just like in T-cell situations here. Clonality doesn't always mean lymphoma. Positive FISH or CGH doesn't always mean melanoma. So again, you want to use things as a tool, helpful technology to help you rather than a crutch, which is used by somebody that doesn't know what's going on. Now, here's an interesting case we had about 6 months or so ago. It's a 10-year-old kid, had this lesion that had been increasing in size. Basically, this biopsy was very, very atypical, diffuse, broad base, lots of mitotic figures near the bottom of this lesion. We called this thing a melanoma. We said there was just no way, even though it's a child, that it's benign, of 9 millimeters in thickness. We submitted to Myriad. Interestingly enough, it came back as likely benign from Myriad. So we sort of didn't believe it anyway. Went on and did wide local excision with sentinel lymph node biopsy. Did have some positive nodes, unfortunately, and 5 out of 8 nodes were positive. Then submitted it to Castle Biosciences. We'll talk about that in a minute, which came back as a class 2 result, meaning that the lesion is going to metastasize. But they said, well, as a caveat, they had not validated this for childhood melanoma. So again, you just have to use these in context. They're coming online, but they're not going to throw away everything else that we have been using for many years. Just to talk a little bit about biopsy technique, you want to make sure that you have a good biopsy that's representative of the entire process. We sometimes are told as residents to excise if you think it's a melanoma. Well, the problem is that we miss the diagnosis clinically of melanoma quite a bit, and so if you had to excise every seborrheic keratosis that could simulate melanoma, you'd never get out of one clinic. So you really need to do a technique like saucerization or something like that that's going to give a representative specimen. But be wary of this technique we call biopsy sculpture. This is where you do a punch of something that's malignant and it makes it look architecturally benign. So here's a punch. It looks symmetrical, small, well circumscribed. There's no pagetoid spread in this section here. So this piece makes it look benign. There's nesting here. And this was actually signed out as a benign nevus by a very prominent dermatopathologist a few years ago. Unfortunately, the lesion recurred and was an obvious melanoma at this point. It was not re-excised on the basis of the original biopsy. So again, be wary of doing punches because they don't allow you to assess symmetry, circumscription. If you're going to do a punch, it needs to kind of punch out the entire thing. So this looks like a flower, but it really is the surface of this fuse of this bomb here. So make sure you're not getting that situation with a punch. And these types of techniques are extremely dangerous, where you're doing just a curettage specimen. These, I think, was asked a question about shave biopsies before. Well, this is even worse. This is a fragmented specimen. It's hard even to pick up any neoplastic cells at all. There's maybe 3 or 4 here. In this one little piece of epithelium, there were some nests of cells here. And this lesion, unfortunately, was called epithelial hyperplasia by the pathologist. He didn't pick up that there was a tumor in the epidermis here, and unfortunately it ended up in a 7-figure settlement against the pathologist. And really, he was kind of compromised by the biopsy. So beware of rendering definitive diagnoses when really can't optimally apply everything, and these curettage specimens, really, you've got to be super careful of those. Just the last thing we'll briefly talk about are some nail unit melanocytic lesions. I think it's not a bad idea to consider performing an X-ray before you do a nail unit biopsy. You need to get into the matrix. This technique is very good where you reflect back the proximal nail fold and then take an incisional or punch biopsy from that area. This guy did his biopsy too distally. He didn't sample the matrix, so he missed the diagnosis. You have to get back into this area where there's a positive Hutchinson sign, and notice that this has the tapering, which is a sign of melanoma. It's growing laterally here, and this is about 6 months of time there. Longitudinal melanonychia, no Hutchinson sign. It's a very symmetrical lesion. If you biopsy these, they often look very, very subtle. You just see these nests, these little dendritic melanocytes. The dendrites are usually just at the level of the basal cell layer. They don't usually extend throughout the epithelium. You can highlight that with immunoperoxidase staining or Fontana-Masson staining. And then if you biopsy racial pigmentation, these are almost like a freckle. Very obvious clinically, but the biopsy is extremely subtle. You just don't see much of anything here. So the clinician may have thought he missed the lesion. If you do a Fontana-Masson stain, it just shows only some scattered melanin granules in here. So these are extremely, extremely subtle lesions, very difficult to diagnose. And this lesion was a melanoma. You might say, well, gosh, this ought to be very ugly and obvious under the microscope. Sometimes these are pretty subtle as well. Just individual scattered melanocytes. Sometimes you'll just see prominent dendrites throughout the epithelium. That's a sign of an early melanoma on the acral skin. So again, a lot of, if you're not a dermatopathologist doing a lot of work on this, you probably need to be careful of even wasting time looking at these. Again, histologic reporting of surgical margins. We have some people that are reporting how far these go to the edge. This is really not standard of care. It's based on clinical. And again, I mentioned this before, I really sort of don't like the menu style reporting of melanoma. Again, it can be done, and a lot of guys like it, but I like to put in a routine verbal diagnosis and add this to it and not have this instead of my verbal diagnosis as well. Last thing we'll talk about is just prognostication of melanoma. The AJCC is heavily using histology to prognosticate. I don't really like this as much. Again, the Clark's levels, they've recommended not using these, but I still do use them in my laboratory. They're a nice check of whether your Breslow's measurement is accurate. If you get a level 2 1.5 lesion, you probably either have an error here, or maybe you actually transpose the decimal point in some way. These are not precise lesions, things to measure though. Melanoma thick skin, it's kind of hard to tell where this level 2 lesion begins and the level 3 lesion begins, and this level 3 lesion and level 4. So these are subjective. Again, here's an example of a Clark's level 3 melanoma. This is an expanding papillary dermis with the solar elastotic dermis pushed down basically by the melanoma here. So again, notice it's expanding the papillary dermis, but a lot of people call this Clark's level 4 when it's really not. It's Clark's level 3. So again, just remember it's difficult to tell where that melanocyte enters the papillary dermis. Ulceration, again, this has been reported by AJCC. This is a very subjective finding. You've basically reported its presence or absent, and a lot of these are actually traumatically induced, so beware of reporting these in thin melanomas. It's really quite common in thin melanomas. Here's a traumatized melanoma, then one that was really ulcerated due to necrosis. And then mitoses, again, we're supposed to report these. And again, if you get a thick melanoma with few mitotic figures, I'm not sure what that means. I still think they can behave badly. And then if you get a very thin melanoma, there's really minimal information about the morphology of the mitoses or where they're located. These are just some problems in mitoses. So I think that the next thing that we're going to probably see, we'll just talk briefly about regression. If you get complete regression of a melanoma, that can sometimes be associated with a bad prognosis, like in this case. Partial regression is, again, somewhat more controversial. Some papers report that it actually improves the prognosis. Unless you get complete regression of the lesion, it's really unclear what that really means. So again, sometimes partial regression is relatively meaningless. So the microscope, really not much of a crystal ball in my opinion, but there is a new test from Castle Biosciences that we're beginning to use now. I want to put a little bit of time on this. This is published patent by Castle Biosciences. They look at 31 genes, and they're not only looking at the melanoma genes, they're actually looking at some genes of the actual immune system of the patient. So it's kind of a profile of how the patient is responding to the melanoma. And they get a class 1 low metastatic risk, class 2 high metastatic risk. These are some of the things that they're looking at. So again, they're not just looking at the melanoma itself. They're looking at things such as angiogenesis, for example, lymphocytic invasion. And this is used routinely, standard of care in ocular melanoma. 90% of ocular oncologists are using this technique. This is a Kaplan-Meier curve. Whenever oncologists see this, they get very excited about it because this is a true differentiating factor here. The P is extremely low there. And it actually, you've got a similar, not quite as impressive, but a similar Kaplan-Meier curve for cutaneous melanoma. And right now, the only thing we really have is AJCC criteria and sentinel lymph node status. Again, if you just take a look at this, this gene expression profile is actually as good, if not better, than this. This is online. You can actually go there and plug your patient's melanoma in there. Again, if you compare this prediction tool, 11 of these patients were thought to be low risk. They were found to be class 2 by this gene expression profile, so this would have picked all these up. So it's about 10 times more accurate. And these are the patients that we would like to be able to tell what their prognosis is in this category here. So if you have this kind of lesion and you have a class 2 result, you should follow it very carefully versus class 1. That'd be the category we really would like to look at. And there actually is a paper just published in JAD just a few months ago that shows this is an independent prognostic variable for melanoma prognosis. It's actually better than sentinel lymph node biopsy as well. We do know that patients with negative sentinel lymph node biopsies can metastasize, so it's no guarantee of disease-free survival. And then the DecisionDx will identify more than 80% of those, so the sentinel lymph node is only about 30%, so it's better even than sentinel lymph node biopsy. So this is the sentinel lymph node Kaplan-Meier, this is the gene expression profile of the primary lesion profile. And just kind of, and there are a couple of papers recently published asking is sentinel lymphadenectomy reasonable to do in thin melanomas? And again, they're saying no. This was in ASCO a couple of years ago. And just recently in the last ASCO meeting, they're saying don't do sentinel lymph node biopsies in these thin melanomas. And here they're saying recently in this ASCO meeting just a couple of months ago, they said don't even do complete lymphadenectomy in melanoma. So we're kind of moving the way that breast cancer surgery did for less and less surgery for melanoma. And if we could use this technique to help us, this is the paper that was presented at ASCO where they showed no significant treatment-related difference in 5 years. So they don't think there's really a survival benefit in completion sentinel lymphadenectomy in these patients. So again, I think this is something we're going to be looking at more as time goes on. Just to show you a couple of examples of the gene expression profile, very thin lesions. One of them had class 1, did fine. The other one class 2, metastasized a year later, even though it was 0.15 millimeters, very, very thin lesion. Here's 2 intermediate thickness melanomas, class 1, metastatic free at 10 years, metastasized about a half a year later. And then both thick melanomas, in contrast, class 1, metastatic free at 4 years, metastasized at 2 years. So this isn't a perfect test, but it is helpful, and I think maybe something that we can use to whether we're going to do sentinel lymph node biopsy in these patients, whether they have 1 or 2 class result on their original lesion. So this is all in your handout. You can see basically this is something that you should consider. So how are we going to integrate all this new technology into pigmented lesion? We had a little group that got together last year. We came up with, these are some of the people that were on that working group, and this is an algorithm that's going to be published in the Journal of the American Academy of Dermatology later this year. We're trying to integrate these new technologies. Obviously, you can't read it all, but it's kind of an algorithm that allows us to plug all this into our clinical practice. So a lot of new advances in melanoma. It's an exciting field, something that we're interfacing with the oncologist about. And if those of you would like to learn more about this this coming summer next year, we're going to have a meeting in Vail, Colorado in August, and we'd love to have you attend and learn more about all these various dermatology techniques and things. Thank you very much.